distinguished guests, colleagues, and friends, a very good afternoon and a very warm welcome to the Hepatitis C Virus Elimination Symposium, Strategies to Eliminate Hepatitis C as a Public Health Concern in Asia Pacific by 2030, organized by the NUS Soswi School of Public Health. Today's event was made possible by platinum sponsor Gilead Sciences, and for that, the school wishes us to extend our most sincere gratitude. First diagnosed in 1989, the hepatitis C virus has since become a significant public health problem affecting 185 million people worldwide. Globally, an estimated 58 million people suffer from chronic HCV infection, of which an estimated 3.2 million are adolescents and children. In 2016, WHO's World Health Assembly called for global elimination of viral hepatitis by 2030, and more recently in May this year, noted a new set of integrated global health sector strategies on HIV, viral hepatitis, and sexually transmitted infections for the period of 2022 to 2030. Based on this roadmap, different countries have developed comprehensive national hepatitis programs and elimination strategies guided by the global health sector strategy. Indeed, procrastination is a luxury we can indulge no more. With that in mind, we very much look forward to hearing from a panel of distinguished experts on what are the best practices and lessons policymakers and practitioners have adopted in their home countries to eradicate HCV, and what more should be done to plug the gaps to reach the end game. I would now like to invite Dr. Hannah Clapham, Infectious Diseases Program Lead at the NUS Soswi School of Public Health, to open today's session. Dr. Clapham, please.
Thank you, Haripriya. Distinguished colleagues, guests, ladies and gentlemen, good afternoon and welcome. Thank you for taking the time to join us today at this very important and timely conversation on strategies to eliminate hepatitis C as a public health concern in Asia Pacific by 2030. I think we'll come back to later what does it mean to eliminate as a public health concern, because there's quite a lot of words there that are not entirely obvious until we talk about them and what they actually mean in practice. Viral hepatitis continues to be a global health scourge. Globally, as we heard, an estimated 58 million people have chronic hepatitis C infection. And 325 million people worldwide live with a hepatitis infection. The socio-economic consequences of HCV cause equally, if not more, devastating consequences. And so HCV elimination is becoming more important than ever before. When I first heard these, I'm new to hepatitis C, and when I first heard these hepatitis C targets, I was impressed, if I'm honest. I think they're very ambitious, and they're something that probably a lot of us working in other infectious diseases should be thinking about. How do we strive for these big numbers, and what do we need to be really serious about the aims that we can do for our infectious diseases? The aim to reduce new hepatitis infections by 90% by 2030, and this is up from 30% by 2020. That is a pretty big increase that's being aimed for in those 10 years. Deaths by 65%, and achieve 80% treatment target of eligible persons by 2030. As we'll hear today, there's a lot that gets to that treatment point. There's a whole lot that has to go on in identifying people who have infection and getting those people into treatment and remaining in treatment. And those are the issues that we'll be hearing about today. In the face of that, around the world, new strategies and programs have been put in place to try and curb the HCV infections. And we're going to hear from our invited experts about the steps that have been taken towards this goal in the Asia-Pacific region. Today, we are here to take stock of the progress that's been made, but also to acknowledge that end goal has not yet been achieved. I would be very amazed if it had been 10 years, 8 years, where are we now, ahead of target. But we need to recognize what the gaps and the barriers are left in public education, prevention, testing, and treatment that will allow us to recalibrate to keep that HCV work as effective as it can be. HCV, of course, now comes to us in a world that's facing a whole host of complex public health issues. There's strains on healthcare budgets and a whole lot of issues going on that limit the length and quality of human lives. Some of those are competing against hepatitis C for funding, but some of them will be things that we need to understand and work together with people in different areas in order to target the hepatitis C. Not only do we need clinicians and people in public health, but it requires a whole of society approach. In our efforts to tackle liver disease more effectively in Singapore and around the world, it is therefore imperative for different stakeholders from the public and the private sectors to increase our knowledge base and to integrate research findings together to effectively tackle these large and complex issues. So it's on that note that the school wishes to express its deepest appreciation for Gilead Science's tremendous support in making today's symposium possible as the event's platinum sponsor. And next, it's my great pleasure to introduce today's distinguished keynote speaker and session chair, who's joining us remotely from Taiwan. I was amazed when I saw this list of accomplishments, honestly. We are so lucky to have this gentleman speaking to us today. So I'm going to give you the spiel, and I imagine at the end you'll be as impressed as I are. Our speaker has dedicated himself to molecular and genomic epidemiological research on chronic arsenic poisoning and virus-induced cancers for over 40 years. His discoveries of multiple health hazards of arsenic in drinking water have led to the global awareness and mitigation of the largest environmental calamity, and his research on end-stage liver disease risk prediction of chronic hepatitis B has pioneered the viral load paradigm in its clinical management, something that I have used in, thought about for a lot of infectious diseases. This paradigm is a really important one. He's published over 750 scientific articles, over 75 books and chapters, all of which have been cited over 93,000 times, and he has a H-index of 140 on Google Scholar. Academics in the audience will be impressed with that. He's currently an I can't say this word, academician, I'll take that out of future speeches, with the Academia Sinica, the National Academy of the Republic of China, Taiwan. He also holds a professorship at the Graduate Institute of Epidemiology, National Taiwan University College of Public Health, which he also served as founding director of from 94 to 97. He later helmed the college as dean from 99 to 2002. This career has spanned a number of organizations, including his previous appointment as the Minister of Department of Health Taiwan from 2003 to 2005, and subsequently Minister of National Science Council from 2006 to 2008. He was elected the 14th Vice President of the Republic of China, Taiwan, and is now also a Distinguished Research Fellow and Academic at the Genomics Research Center of Academic Sinica. See? Wow. So, he's obviously won a lot of prizes along the way for these, and I'm going to list a few of them now. The Presidential Science Prize, the Order of Dr. Sun Yat-sen with Grand Cordon, the Cutter Lectureship on Preventive Medicine of Harvard University, the Knowledge of the World Award from Johns Hopkins University, the USA, and the Officier of the Ordre des Palmes Académiques in France. A long list and really important contributions to academia and public health. So it's with my great pleasure that I invite our keynote speaker, Prof Chien-Jen Chen, to share with us Taiwan's roadmap to hepatitis C elimination. Prof Chen, please.
Thank you very much, and Dr. Claire Pham, for your very kind introduction. It is really my pleasure and honor to be invited to give this keynote address at the Hepatitis C Elimination Symposium. My topic today is Taiwan's role to hepatitis C elimination. And countries with high incidence of liver cancer also have a high prevalence of chronic hepatitis C and hepatitis B infection. And as shown on this slide, there was a significant increase in global deaths from liver cancer and cirrhosis from 1990 to 2013. And the median percentage of increase was 60% for liver cancer and 45% for liver cirrhosis. And the increase was especially striking for liver cancer and cirrhosis related to hepatitis C. The World Health Organization have proposed the 6 targets area for the global elimination of hepatitis B and hepatitis C by 2030. Taiwan has achieved the targets of hepatitis B vaccination program in 1989 and brought an injection safety program in 1990. The harm reduction program for the people who injected drugs, PV, was started in early 2000 and reached the targets in 2005. And the most challenging targets for viral hepatitis elimination in Taiwan include a 90% diagnosis coverage of hepatitis B and hepatitis C with 80% treatment coverage of eligible patients. A national program of antiviral therapy for chronic hepatitis B and C was launched in Taiwan in 2003, and from 2003 to 2005, the eligibility criteria for the antiviral therapy were quite restrictive. We gradually loosened the criteria in 2006 and 2009 in order to treat more patients. Liver biopsy was needed initially, but could be replaced by serum HCV RNA level after 2009. We started to reimburse DAA treatment for high-risk chronic hepatitis C patients who had detectable serum HCV RNA level, prior treatment failure, and liver fibrosis score greater than or equal to F3 in 2017. The DAA treatment was available for all chronic hepatitis C patients in the phase 2 started in 2019. This slide shows the chronic hepatitis C patient newly treated with antivirals in Taiwan from 2003 to 2020. More than 90,000 chronic hepatitis C patients were treated with interferon-based therapy before 2017. And as you can see here, more and more chronic hepatitis C patients were treated with DAA from 2017 to 2020. And this slide shows the age-adjusted rate of chronic liver disease and cirrhosis mortality, hepatocellular carcinoma mortality, and hepatocellular carcinoma incidence from 1979 to 2018 in Taiwan. As shown in panel A, you can see there's a gradual reduction in the mortality from chronic liver diseases and cirrhosis after 2003, and this is also true for the reduction in SCC mortality and SCC incidence after 2003. And this slide shows that compare with the baseline period from 1999 to 2003, the mortality from 2014 to 2018, and you can see there's a very significant reduction in chronic liver diseases and cirrhosis mortality. It reduced around 26% during this period of time, and SCC mortality decreased 50%, and SCC incidence decreased more than 50% in Taiwan. The 2030 targets of World Health Organization Hepatitis C elimination program include 90% reduction in HCV incidence and 65% reduction in HCV-related mortality through reaching HCV screening rate of 90% and treatment rate of eligible patients as high as 80%. And in order to achieve the 2030 target in 2025, Taiwan's Office of National Hepatitis C Program decided to set a goal of treating 250,000 chronic hepatitis C patients with DAA by 2025. And we can reach the goal of 2030 in 2025. Taiwan Hepatitis C Policy Guideline proposed the 3 core strategies, including precision public health, continuum of care, localized care delivery, with 3 policy directions: therapy spearheads prevention, screening supports therapy, and prevention secure outcome. And 8 actions will be taken to reach the goal of hepatitis C elimination in 2025 in Taiwan. The first action is to secure the adequate budget, the government will provide 1.7 billion US dollars in the coming 8 years. And we try our best to lower barriers of access to care, and our National Health Insurance Administration will loosen treatment criteria. We also try our best to implement precision screening strategies, and various programs will be implemented for different population groups. And we try our best to maintain continuum of care to leave no one behind, and the strengthening of our preventive measures for specific high-risk population, and promoting liver health literacy on liver disease management and prevention of new and reinfection, as well as the evaluating outcome of policy and intervention, as well as encouraging innovation, research, and development. And through the 3 strategies of precision public health, continuum of care, and localized care delivery, and as well as 3 policy directions of therapy spearheads, prevention, screening, support therapy, and prevention secure outcome. And we try to increase the chronic hepatitis C treatment coverage, and try to lower the new infection rate of chronic hepatitis C patients, as well as the reduce the chronic hepatitis C related mortality. Eliminate hepatitis C by 2025. And this slide shows the number of DAA treatment by month and various genotype from 2017 to 2021. And as you can see, by now, more than 141,000 patients has been treated by DAA. At the very beginning, the criteria is quite stringent. They need to have a F3 or worse status, and have all prior treatment failure. And then on the phase 3, there's no restriction for us to treat chronic hepatitis C patient with DAA. And this slide shows the efficacy of DAA treatment and reasons of missing SRV result, SRV12 results. And as you can see here, the real-world effectiveness of DAA treatment is on as high as 98% in total. And in recent 3 years, the effectiveness of DAA treatment are over 98%. And the reason for missing SVR12 results, most of the reason is the early result. But we try our best to have more patients to be tested for the SVR12 result. And we also try our best to engage in community-based hepatitis C screening in the population. And as you can see here, and for the general population, we try to screening everyone in Taiwan aged 45 to 79 years old. And for the Aboriginal population, we expand the age span from 40 to 79 years old. And we cover all these screening program in low-risk area, middle-risk area, as well as high-risk area. And we also pay more attention to those patients who have the extrahepatic morbidities, including patients with diabetes or end-stage renal diseases or rheumatoid arthritis, chronic kidney diseases, as well as cardiovascular diseases. For the special population, we carry out routine screening for the dialytic patient, HIV-infected people, and prisoners, and methadone maintenance therapy patient, as well as patients with sexual diseases. And in the medical institution, we also carry out a routine screening to check their hepatitis C and hepatitis B infection, and for the high-risk group, and then we carry out the screening as well. And as you can see here, for the Health Promotion Administration's hepatitis B and C screening program, and the number of screenees by July 31st, 2022, more than 2 million people have been screening. And as you can see, in recent years, due to the COVID-19, the number of screenees was slightly lower than before this outbreak. And most of the screening program was carried out by clinics in the community. And the main force in hepatitis B and C screening, in addition to the clinics, public health centers, are also important. And some of this B and C screening will carry out in district hospital, regional hospital, and medical centers. This slide shows the hepatitis B and C screening program results. And as you can see, the overall prevalence of anti-HCV infection in Taiwan is 3.1%, and some cities or counties have higher prevalence, including the Yunlin County, 7%, and Jiayi County, 6%, and Jiayi City also 6%, and the Taidong City is around 4%. And this slide shows the HCV RNA testing rate, and the average testing rate is 72% in Taiwan, and some cities or counties have HCV RNA testing rate higher than 80%. And for those who were HCV RNA positive, the DAA treatment rate in average was 89.8%, is quite higher than 80%. And as you can see, this DAA treatment rate was considered very satisfactory in Taiwan. And I would like to share with you some HCV care cascade in special group. For the dialytic patient, as you can see here, there's more than 77,000 dialytic patients here, and 99.9% of them has been screened, and 11.3% were anti-HCV positive. And among anti-HCV positive, 85% of them have been tested for HCV RNA, and 71% were HCV RNA positive. And among these HCV RNA positive patients, 95% have been treated with DAA, and the overall treatment in this dialytic patient is 81%. And this is the HCV care cascade for HIV patient in Taiwan. As you can see here, the anti-HCV screening rate was quite high, it's 98%, and HCV RNA testing rate was also high, around 85%, and the DAA treatment rate is around 93%. So the overall treatment rate of HCV patient with an HIV infection was 78%. And for the HCV care cascade for patients in the prisons in Taiwan, and we have around 43,000 prisoners, and 39% have been screened for anti-HCV. For anti-HCV positive one, 86% have been tested for HCV RNA, and among the HCV RNA positive person, 83% were treated with DAA. The overall treatment rate is 28%. And HCV care cascade for patients with opioid substitution treatment, OST, in Taiwan. As you can see here, the anti-HCV screen rate is 78%, and among the anti-HCV positive one, 84% have been tested for HCV RNA, and HCV RNA positive person have 94% been treated with DAA. The overall treatment rate is 61%. And in addition to this special high-risk group, we also try our best to provide a screening and also testing and treatment for the patient identified from the screening program I just mentioned. And in total, the general population aged 45 to 79 years old in Taiwan is around 10 million, and 18% by now have been tested for anti-HCV, and among anti-HCV positive persons, around 50% have been tested for HCV RNA. For those who were HCV RNA positive, 90% were treated with an DAA. So overall, there's only 8% of patients have been treated. This is the program we have to accelerate and try to have a better achieve to reach the goal as soon as possible. And for the general population, and if we look at this data, not only from the screening and also from this clinic testing, and you can see there's an anti-HCV screening rate increased up to 42%, and anti-HCV positive person have 65% have been tested for HCV RNA, and 95% of HCV RNA positive person were treated with DAA. So if we include this general population screening as well as the clinical-based screening, and 50% of this patient in Taiwan have been treated with DAA. And we also try our best to treat patients with the comorbidity. And this slide shows the HCV care cascade for DM care program patients. And you can see here, 56% of the DM patients have been screened for anti-HCV, and HCV RNA test for anti-HCV positive, 71%, and DAA treatment for HCV RNA positive person is 98%. So 39% of DM patients were treated for HCV infection. And with regard to this HCV care cascade for early CKD care program, and you can see here, among us more than 400,000 early CKD patients, 60% have been screened for anti-HCV, and HCV RNA test was carried out in 71% of anti-HCV positives, and the treatment was carried out in 97% patients who were HCV RNA positive. Overall, 42% of early CKD patients in the program have been treated with DAA. And this slide shows the HCV care cascade for pre-end-stage renal disease care program. And here, as you can see, the screen rate was also very high, around 67% for anti-HCV screening, 71% for HCV RNA testing, and 96% for DAA treatment. So overall, 46% of pre-end-stage renal disease patients in the program have been treated with DAA. So from my presentation, and you can see that Taiwan Hepatitis C Policy Guideline has highlighted 3 core strategies, including precision public health, continuum of care, and localized care delivery, with 3 policy directions: therapy, spear health prevention, screening support therapy, and prevention cures outcome. And Taiwan is on track to eliminate HCV by 2025 based on strong commitment by the Ministry of Health and Welfare to finance this national program. And the HCV awareness and active screening program, as well as funding for the linkage to care program, need to be reinforced in the near future. And the goal of hepatitis C elimination is to treat 250,000 chronic hepatitis C patients with DAA by 2025, and now we have a total of 142,000 chronic hepatitis C patients being treated with DAA by August 31st, 2022. So we still have to do our best to try to treat more than 110,000 chronic hepatitis C patients in the coming 3 years. So, but we still expected that Taiwan may achieve the WHO's goal of HCV elimination by 2025. With that, I would like to thank you very much for your attention. Thank you.
Thank you, Prof Chen, for sharing your insightful thoughts. It's very much heartening to hear from you that you will be eliminating HCV infection in Taiwan in another 3 years. Up next, we have Dr. John Ward, Director for the Coalition of Global Hepatitis Elimination, the Task Force for Global Health, who will talk about progress toward HCV elimination in Asia and globally, essential components of effective hepatitis elimination programs. Dr. Ward is unfortunately unable to join us this afternoon. We would, however, be sharing with you a recording of his presentation. Dr. Ward's work spans across the practice of epidemiology, laboratory science, clinical trials, public health practice, policy development, health communication, education, and clinical medicine in the prevention and control of HIV/AIDS and the elimination of viral hepatitis over the course of his illustrious 38-year career. Globally, Dr. Ward advises hepatitis elimination activities at WHO and other organizations and guided the launch of pioneer HCV elimination programs. He directed the Coalition for Global Hepatitis Elimination of the Task Force for Global Health, providing a community of practice for hepatitis elimination programs to collaborate, receive technical assistance, and participate in operational research. Nationally, he was also instrumental in directing the US CDC Division of Viral Hepatitis with responsibilities for viral hepatitis surveillance, prevention, and research. As director, Dr. Ward revised national recommendations for hepatitis vaccination and testing, including the first population-based recommendations for hepatitis B and hepatitis C testing. It's our pleasure to now hear from him.
Hello, I'm Dr. John Ward. I'm Director of the Coalition for Global Hepatitis Elimination at the Task Force for Global Health in the United States. It's my privilege today to join you and give you an update of our progress toward hepatitis C elimination in Asia and globally, with a focus on the essential components of effective hepatitis elimination programs. These are my disclosures. I'd like to go over and give you an update of our global hepatitis elimination goals, the essential components of effective hepatitis elimination programs, what are the status of programs around the world, and what are the initiatives to build capacity for hepatitis elimination in the future. WHO estimates we have about 58 million people living with hepatitis C globally, including 10 million in the Western Pacific region of WHO and 10 million in the Southeast region. Globally, we have an estimated 290,000 deaths and 1.5 million new infections every year. Now, the first global goals for hepatitis C elimination were put forward by WHO in 2015, with relative targets calling for a 90% reduction in incidence, 65% reduction in mortality by 2030. When the global strategy was renewed this year and endorsed again by the World Health Assembly, there was the addition of what's called absolute targets, whereby countries could shoot for reductions to achieve rates of incidence of 13 and 5 per 100,000 by 2025 and 2030, respectively, and declines in hepatitis C mortality to 3 and 2 per 100,000 over those same two intervals. The WHO global strategy also includes indicators to monitor the implementation of certain key policies, plans, and services needed to achieve elimination. And that's one of the key areas of our activities at the Coalition for Global Hepatitis Elimination, is to help countries put in place the strategic information, the national planning, the implementation of services appropriate for that burden of disease and health system, a focus on health equity to achieve that, to assure that all populations benefit from hepatitis C prevention, testing, and treatment, to have data that can be used to monitor the performance of various programs in the country, to identify ways those programs can be improved, and to have data to document when your goals are achieved. And we do this by looking at systematic reviews of the literature, and then we also work with local partners of civil society, clinicians, ministries of health, to bring together data to assess what's in place regarding strategic information, the plans, the programs, and the services being delivered to all communities in the country. And here are the countries that we have worked with to date and are working with currently to develop their profiles. When we done an assessment of national action plans around the world, we could only find 2 through systematic reviews and working with local partners that I've just described. They varied widely in their targets for elimination, with very few having a explicit target for reductions in HCV mortality, which was one of the largest gaps. Many of them did recognize the importance of blood safety and of addressing stigma for people living with hepatitis C, among those particularly marginalized, such as people who inject drugs and the incarcerated. However, a much smaller proportion had plans to identify ways of improving access to diagnostics or to cover the cost of programs for prevention care and treatment. The gaps in strategic information is particular concern is shown here at our global assessment, with most countries have gaps in the quality of their data to track mortality, new infections, or the number of people living with hepatitis C. So there's a lot to be work to be done there. And so models are often used to address those gaps. The Global Burden of Disease program of the University of Washington regularly puts out mortality data for a host of diseases, including for hepatitis C. And the most recent data for 2021 is shown here, showing there have been increases over time in mortality based on their estimations, and that mortality rates remain far above these mortality targets, that reductions that have been set by WHO. When you look at Asia, Japan has the highest mortality rate from hepatitis C in the region, followed by the other countries shown and regions shown here. Other Asian countries have lower prevalence, as you can see, including Singapore, as shown here, which is approaching the 2025 mortality target, which is very promising news. But even in these countries that have lower mortality rates, they remain above the mortality targets to be indicative of elimination. When we begin to look at the actual programs in place, we see that most countries do have national treatment guidelines for hepatitis C. Many countries have access to generic medications, which greatly reduce the cost of hepatitis C treatment. However, a much smaller proportion have financing in place to relieve patients of copays for hepatitis C treatment. And a lack of testing policies is a real concern because only about 1 in 5 people with hepatitis C globally are aware of their status, and diagnosis is the first step toward receiving treatment. For marginalized populations, such as people who inject drugs, prevention programs specific for their needs are needed. However, most countries do not have strong prevention programs for people who inject drugs in the delivery of safe injection equipment, or decriminalizing the possession of injection equipment so that these prevention programs can be put in place and people feel free to use them. A regional review of national plans and policies recently published by the Western Pacific Regional Office of WHO show that the number of countries with national plans has improved over time, but do not represent all the countries in the region. A number of countries, as shown on the left, have put in place financing to help reduce the cost of treatment and care for hepatitis C to patients, including Singapore. And when you China is one example of a country that has progressively expanded access to the point now where their national health plan covers the cost of HCV medications for their patients. For Singapore, it's estimated that less than 1% of people are living with hepatitis C infection. Mortality, as I've mentioned, is approaching the 2025 target set by WHO, and the mortality appears to have decreased slightly over the last 5 years. People who inject drugs continue to be a population with a high proportion infected with hepatitis C, and their incidence rate is quite high, much higher than the target set by WHO for people who inject drugs. So a key population in need of greater services. Singapore could benefit from a national action plan that has targets for elimination, screening recommendations appropriate for the populations beyond people on hemodialysis, and better prevention services for people who inject drugs. Pardon me. There are examples of model programs in other countries. Egypt, once the country with the highest prevalence of hepatitis C globally, after years of putting in place treatment programs around the country, recognized that diagnostics were inadequate. The president called for every adult to be tested at least once for hepatitis C, setting in motion a very robust hepatitis C testing program available throughout the country in community and clinical settings, resulting in over 70 million persons being tested, over 2 million being found to have evidence of been infected with hepatitis C virus, and over 1 million currently infected, with high proportion of those being referred to care, being treated, and cured. And then when you look at their profile, they have had large reductions in the change in new infections and large declines in deaths, approaching their targets for hepatitis C elimination. Rwanda is another example of a country that had a high prevalence of about 4%. Again, put in place a very testing and treatment program available in a variety of community and clinical settings, including primary care, and receiving and negotiating affordable diagnostics and treatments for their country. And again, as a result of this very robust care cascade, they have had large declines in prevalence and are on their way toward achieving their hepatitis elimination goals. And there are other examples as shown here that countries in Asia can take lessons learned from to guide their development of programs for hepatitis C elimination. We have a number of effective technologies and strategies already in place, but there are others that could help us, such as better diagnostics for point-of-care testing for hepatitis C that would make testing and initiation of treatment at the single clinic visit more feasible, and further efforts to simplify care so that primary care physicians and pharmacists, nurses can deliver hepatitis C treatment as it's being done in the countries that I have highlighted previously. When you look at sustainable financing, just wanted you to be aware of a tool that's available on our website at globalhep.org that helps countries develop a budget-based plan for hepatitis C elimination. With this tool, you can input the burden cost of diagnostics, cost of treatment, the year of your elimination goal, and the model will tell you how many persons need to be tested and treated and at what cost to achieve that goal. And I urge you to go and find out more information about how this tool can be used to guide the planning for your country. The Global Fund also has recently revised their funding criteria so that they now will allow funding for testing for hepatitis C and for hepatitis B beyond persons that were already diagnosed with HIV. So this is a big change and a new opportunity for funding of hepatitis C testing and treatment by the Global Fund. We at the Coalition recognize that the pandemic was a setback to hepatitis C elimination in many ways, but also revealed some opportunities such as stronger diagnostic capabilities in countries given the large resources that were made available to improve SARS-CoV-2 testing. And we're very interested to look at case studies of how this new diagnostic capacity can now be applied to hepatitis C testing. And if you have examples of that, please contact us so we can get more information about those. Also, we realize that we need more global awareness of the health threat that is hepatitis and how that threat can be reduced and eliminated through better prevention, care, and treatment. So we recently convened a side event at the UN to bring countries together to form the first UN group of friends of countries committed to hepatitis elimination. Let me show you a clip from that day.
We truly are at a miraculous moment. I sense a real momentum now because we have these great drugs and very good tests.
I want to thank the Coalition for Global Hepatitis Elimination, the Task Force for the Global Health, and all the member states and partners here today for bringing us together. We estimate that there are currently over 300 million cases of chronic hepatitis B and hepatitis C worldwide, and an estimated 3 million people getting newly infected each year and 1.1 million deaths. And this is just simply put too much.
Hepatitis has been neglected for far too long.
We are very glad to share our experiences in this regard.
Egypt expressed the full support to the group of friends and the opportunity to lead the effort for the first year.
Portugal supports the creation of the UN Group for Friends to Eliminate Hepatitis, which we will be proud to join.
Therefore, Malaysia invites all member states to join us in forming the UN Group of Friends to Eliminate Hepatitis.
Chile joins happily and very determinedly this call to launch a UN Group of Friends for Global Elimination of Viral Hepatitis. We strongly support the world joining these public health strategies for the control and elimination of hepatitis by 2030.
We are willing, able, and are here to be part of this friendship circle. The time has come for decisive collective action, which is why we appreciate this gathering.
We are overwhelmed because hepatitis in Sierra Leone has increased considerably. So on behalf of the government of Sierra Leone is willing and happy to join the group of friends for the elimination of hepatitis.
There is an African proverb that says, if you want to go fast, go alone. If you want to go far, go together.
So thank you for your time. I hope this information has been useful to you. Please come to the Coalition for information, sign up for our newsletter, follow us on Twitter at Global Hep, and contact me about any questions you may have about the information, wanting to work with us to improve your program and for your country to join the UN group of friends. Thank you again.
Thank you, Dr. Ward, for sharing your insights on this. Next up is the panel discussion and question and answer session. Moderating today's session, we have Dr. Chien-Jen Chen, Chief Executive Officer, the American Chamber of Commerce. Our panelists, Dr. Jasmine Poo, Director, National Hepatitis C Program Office, Ministry of Health and Welfare, Taiwan. Dr. Lee Tao Hong, Head, Antimicrobial Resistance Coordinating Office, National Center for Infectious Diseases. Dr. Hannah Clapham, Infectious Diseases Program Lead and Assistant Professor, NUS Sosby Hawk School of Public Health. And joining us remotely from Taiwan, let's welcome back Prof Chen, Academia Sinica. Last but not the least, joining us remotely from Australia, Dr. Alisa Pedrana, Senior Research Fellow, Co-Head Public Health, Co-Head Implementation Science Group, Eliminate Hepatitis C Australia Coordinator.
Thank you so much, everyone, for coming in person today, and also for those of you who might be watching the video recording. And of course, an honor to be together with these panelists, including Professor C.J. Chen. There's actually a very strong representation of Taiwanese today, because I too was born in Taiwan and consider myself Taiwanren. So excuse us if we talk about Taiwan a little bit more than usual, because clearly it is such a wonderful case study for the elimination of HCV. And that is why, again, it is such an honor to be able to be part of this panel to talk about something that is clearly within reach, especially for Singapore, as the data that Dr. Ward shared just now. So for this panel discussion, I really want to encourage all of you to ask your questions, because I think it's a rare opportunity to ask your questions directly to the experts on the panel and on the screens, to my right and to my left. And so if you miss this opportunity, I think you're going to kick yourself later. So please do ask your questions. But let's start off first. I want to welcome Dr. Pedrana to the panel all the way from Australia. Hopefully you can see us. Yes. Thank you for the encouragement. We've been talking a lot about this elimination of HCV, and from a public health perspective, it is one of the best examples that we have seen so far. But those of you who are students of history also know that it is definitely possible, because we have done the same with polio and smallpox. So HCV is going to join that group of diseases that we're going to eradicate and eliminate from this earth. So very encouraging. Looking down to Australia, Dr. Pedrana, I wonder if you can tell us how Australia plans to approach HCV elimination, the action plan, the elimination plan that Dr. Ward talked about, and what kind of partnerships you have been forming at the community level, and possible harm reduction lenses that you've applied. Dr. Pedrana?
Thanks for inviting me to join the panelists today, and thank you also to the two fantastic speakers, Dr. C.J. Chen. It's so great to hear about Taiwan's success story. We in Australia have been following Taiwan very closely and trying to adopt some of your successful strategies. So, as you mentioned, in Australia, we are committed to the elimination of hepatitis C and also hepatitis B by 2030. And at the moment, we are about to release our 6th national strategy for hepatitis C, and both the federal and the state governments are very much committed to ensuring that we meet those targets. When we look at our approach in Australia, we have a long history of working in close collaboration with both community partners and healthcare sector, and also the research and the academic sector. We've formed a strong alliance both in HIV and in the responses to hepatitis C. And so what we've been able to pull together is, since the DAAs were released onto the National Health Scheme in 2016, very similar to Taiwan, we saw a rapid increase in the uptake of treatment, which is fantastic. We saw a lot of people who were already quite sick, previously diagnosed with Hep C, initiated onto treatment very quickly and had their Hep C cured. So we've had some fantastic results initially. And what we've seen is progress to date at the end of 2021, 56% of people living with hepatitis C have since been tested and cured. So we've made great progress since 2016. Unfortunately, similar to Taiwan, we are seeing sort of the decline in treatment initiation. And this really does highlight some of the value in working in close partnerships with our harm reduction sector. In Australia, most of our new transmissions are amongst people who inject drugs. And so ensuring that we engage that community effectively, that they have access to testing, including new diagnostics such as point of care testing, and that they have the ability to be linked to care quickly. And so they're not delaying that. And that's something that we have found, that people will often be tested and they're not linked to treatment. And so we want to make sure that we are closing that gap and that everybody diagnosed with Hep C can get access to treatment quickly, but that we're able to extend testing out into community settings. So that's beyond hospital services, beyond alcohol and drug treatment centres, and out into areas where people aren't getting access to hepatitis C testing. And that includes in homeless services, mental health services, as well as, pre and post the justice system. So probation and parole, where we know is a high proportion of people who inject drugs that also have prison incarceration history. And that's where we'll be focusing our efforts and working with those community organisations already linked to these populations.
Thank you so much, Dr. Padrana. Just a question, because Australia is quite different than some of the countries we have represented on the panel today, mainly due to your geographic size. And Prof Chen had talked about precision public health and the use of these part of the elimination plan. So from a precision public health and the use of big data perspective, can you tell us a little bit more about how Australia is tackling that? Because you do have such a large landmass. If people don't know this already, you know Australia is a continent, right? So they're dealing with a continental problem, not just a country problem or a little island problem. Dr. Padrana, what are your thoughts on this aspect of having an elimination plan?
Thank you for highlighting the immense challenge that we have in Australia. Really, it's a geographical challenge. We have people living right across the outskirts of Australia, mostly, and then also within. So we do have that additional challenge in terms of reaching people where they are currently. And we're fortunate that our primary healthcare system does quite a good job at covering people and generally people have good access to primary care services. However, we do know that for getting the message out into communities that may not be aware that there are new treatments is a challenge. Sort of communicating with the general public can be difficult, particularly when we're talking about diseases that have a history of stigma and discrimination attached to them. So not everybody is quite open with their hepatitis B or hepatitis C status. And so there needs to be some consideration with how we communicate with key populations about accessing testing and treatment. And one approach that we've taken in Australia is really to work with the different state and territory governments and work with the peer drug user organisations to develop health promotion campaigns that are peer delivered and peer driven. And so a lot of the messaging that we're coming up with is much more sensitive and specific to the communities that we want to reach. They're using the language that's needed, and it's also using the communication channels that we know are effective to these communities. And I think that's been a real success story in Australia to date, is being able to ensure the messages about hepatitis C cure and treatment and the success that we've had today gets out to the people who really need to hear it.
Thank you very much, Dr. Padrana. I'm now going to turn to my left, Dr. Pu from Taiwan. You are at the forefront of Taiwan's efforts to eliminate hepatitis C. Can you, excuse me, Can you tell us more? I mean, the data that Prof Chen showed was impressive. And by the way, my mother is originally from Taiwan, which is east of the island, and it didn't have very good numbers there. So, so even for a smaller island like Taiwan, you've got quite a lot of variability across the various parts. So tell us more about what you're doing in Taiwan and some of the challenges that you face.
I think you pick up that pretty quick. Just flash it. Okay, let us start from Taiwan. For the start, from the very beginning of starting of this program, we find it some particular area like Taitung, Hualien, or even from Pingtung. So that's a very remote area to, comparing to Taipei. Their most challenging problem is that the lack of the hepatologist. Because in the beginning, the DAA is only prescribed by the hepatologist. So we have this, identify this problem, work with the local healthcare, local city, local government. We have this health bureau. They foresee their county and all the health resources, and then reach out to the medical society. They were very enthusiastic to help. And then the treatment, the prescribing qualification loosened. So every physician can prescribe DAA now. And a lot of the collaboration the model has been built. So the lack of medical specialty is now not a problem now. But they started slower. So you got the number still on the rise. So, I think they can use this number. A lot of the below the average counties and cities, they are really catching up speed because of this routine progress. So that's one of the things we are doing. And the most challenging now is still the general population screening. As you see from the numbers CJ just showed. So we are working on that. We try to enhance the system, make it more efficient, more simplified, and more accessible to general population. So, but that's still the most challenging part.
Thank you so much. I did have one question because I was looking at the slides, and I really liked seeing, I don't know what you call it, but that flow.
Care cascade.
Right, yes, a care cascade. That was very informative, especially as it was stratified by the different groups. But when it got to the end about the percentage who had received treatment, what are, say, the top 3 to 5 reasons why such a high percentage still haven't received treatment? Is it lack of time? Is it lack of a specialist? Do we just need more, what do we need to get to a higher percent treated?
I think the most lack of the lowest number is the prisoner. The patient in the institutions. I think that's because the other major challenges that we collaborate, within our ministry is difficult, a little difficult, and we collaborate with the local government, a little more difficult, and then we reach out to other administrations, other ministries or other disciplines. They have their own way of working. And when we reach out for patients in prisoners, there are a lot of things we need to collaborate on. We started from screening and referral and treatment. So that's a care, continuum of care. And they, especially within the prison, they are even more difficult. But we started to have this collaboration meeting for each county, city. after we're doing that, people, the test on track, and then COVID hits. And the institutions are especially afraid of, the infectious disease in their institutions. So things are sloping a lot. So the numbers I am trying to catch up on would be in those places, areas.
That makes a lot of sense. Competing interests and alignment of interests is not that easy to achieve. Dr. Lee, you are based here in Singapore, you're on the ground, you're a clinician. What are you seeing here in Singapore? One thing is, clearly the prevalence of HCV infection is much lower in Singapore than some of the other countries that Dr. Ward mentioned in his presentation. But yet at the same time, one thing was, okay, it's not that important, because compared to other things. The other thing was, wait a minute, this thing is such low prevalence that we could actually more easily eliminate it in Singapore. So as a clinician, as someone who sees these patients, what are your thoughts on eliminating HCV in Singapore, and also maybe a commentary on that high-risk population as well, which is also quite low here, right?
Right, thanks. So on the outset, Singapore has actually all the right ingredients to eliminate hepatitis C, I would think. We are a small island, even smaller than Taiwan. We have a generally efficient healthcare system. So if you were to come up with a cascade of care, we should be able to hit that target set by WHO. I think the challenge, number one, is that we currently do not have a national elimination program or a strategy that is laid out systematically what to do. As a clinician, I treat my patients with HIV and hepatitis C co-infection. So I recognize, or we recognize this group as a high-risk group because of similar routes of transmission. Separately, the highest risk group in Singapore will be the people who inject drugs. So I think those will be a target group to really have the first interventions. And I think this is already in place. Hepatitis C screening is offered to the prisoners in the prison services, and we have already started treating these patients in rather large numbers. I do not have the specific data, but it's through discussion with my colleagues that we are starting to treat. The other aspect is that the hepatitis C drugs, we have got 2 that are listed on the formulary in terms of getting subsidy. So these are really useful. It has been listed since 2020. And from there, we have really seen an uptick in the number of patients who are treated. And I think if we were to have a elimination program, then I think we would really hit that target sooner rather than later. I would usually say, just get them diagnosed, get them come to the clinic, and we will take it from there. As a clinician, I think that will be that will actually be the simplest thing to do. But first difficulty is to get them diagnosed. I think that's the major challenge. Thank you.
Well, I think you're right that in order for us to actually get anywhere, we need to have a plan. And that plan would then look at metrics, you look at all this. I mean, there's actually so many frameworks we can already apply that I think would make sense also in Singapore. I guess the question also, one of the things that struck me about Singapore, because there's no plan, the screening is quite low because it's only targeting high-risk populations. In your experience, for your clinical practice, what would you think of maybe, okay, so there's no plan, but would you be able to expand screening? Would you encourage your fellow clinicians to expand screening? Or is that really having to be done at the national level?
I think it depends on the strategy. Surely there should be a strategy where we could triage or prioritize some of the strategies. I think the lowest hanging fruit would definitely be the at-risk population, so people who inject drugs, HIV positive people, gay and bisexual men who have sex with men, and those who have recent sexually transmitted infections. I think these are the highest groups in Singapore. And I think if we were to focus on these groups, and then we could channel our resources appropriately first, and then subsequently we could then channel our resources to those more lower prevalence group that will require more case finding. But of course, as time goes by, then it probably costs a bit more just to find a single case. But I think as a whole, it probably does make sense to make it in a gradated approach, going for the highest risk first.
Thank you so much, Dr. Lee. Do we have Prof Chen with us? Because, oh, he's to my right on the screen. Hello, Prof Chen.
Hi.
So I promised to prioritize audience questions first. So even though I did give them some prepared questions, I'm gonna go to your questions first. And the one that received the highest number of votes is, I think, something great for Prof Chen to answer, because it's about the lack of this national elimination plan for Singapore. And it's actually about alignment of government interests. The question actually reads, how do we entice the government, such as the Ministry for Home Affairs, the Ministry of Health, as an example, to treat a drug-related disease? As Dr. Lee has mentioned, in Singapore, there is an association with people who inject drugs. So how do we entice the government to treat this type of disease and achieve elimination goals? Prof Chen, since you have led nationwide efforts on a number of fronts, I think informally, if you could advise the Singapore government, what would you say to them? And maybe you've already said some things to them. So if you could give us a sneak peek of what your thoughts are about Singapore.
I think each nation has its own difficulties and how to allocate their public health resources to treat many kinds of diseases. And I just saw that since the prevalence of SCV in Singapore is quite low, and I totally agree that it will quite expensive to identify any infected people. In Taiwan, our prevalence is at 3%, and it's much higher. And the reason for Taiwan to tackle this SCV as a very important public health is that we have high mortality from liver cancer. And this is why we put more emphasis on that. And I would like to emphasize that this kind of effort not only the responsibility of the Ministry of Health and Welfare, we need also the help from the Ministry of, say, Justice for us to get into the prison or some other special area. And we also need the support of Ministry of Interior in order to have a nursing home and to be visited and so forth, and also the Ministry of Education and to promote the health education. I think interministerial effort is very important to share these problems. And for hepatitis C, although Singapore has no national policy, but I would suggest that in Taiwan, we found that the HCV high prevalence, in addition to those who were HIV positive, or there were dialytic patients and people there were PV and so forth. But another, the so-called second highest group of prevalence is this dialytic patient and also chronic kidney disease patient as well as diabetes patient, and that's the reason why we try to move our focus to so-called the second highest risk group for screening. And I think this is more precise and more effective, cost-effective. So maybe in Singapore they can try to identify the HCV infected people in those patients such as diabetics and renal disease patients, and as well as rheumatoid arthritis patients or even cardiovascular disease patients. They have higher prevalence than the general population. And in Taiwan, we also focus on the aboriginal area. In some aboriginal area, they have, and also the remote islands, and they are using that's an medical injection a long time ago, and they got infection. And so this special group, without the so-called very good stereo needle syringes and in the area, they might need more attention to it. And these are also high-risk group. Our precision public health means that to identify the people according to their risk, and stratification, and then we can have a more cost-effective way to identify the HCV-infected persons. Thank you.
Thank you very much. In fact, you made a great segue because one of the questions was about precision public health and precision screening. And okay, I have a little bit of a conflict of interest because I am a member of the Precision Public Health Asia Society, where we do advocate for the use of big data to help with a variety of diseases. And it's not just genomic data that we can use across a variety, but also geographic data, the kind of tracking data you can gather. So I think with this question about precision public health and precision screening, Prof Chen, is it possible, you mentioned it several times through your presentation, were you only referring to the screening piece, or do you have bigger plans in terms of diagnosis, treatment, and maybe even on the population level, maintenance? I'm not sure if I'm articulating it correctly, but want to know more about this precision piece that you mentioned.
Okay. In Taiwan, we have a national health insurance system, and more than 99.7% people are under only one payer health insurance system. And all this information, including this diagnosis and testing, as well as this treatment, all in this reimbursed by national health insurance system. So we do have this big health data for 23 million people in Taiwan, and we can use data linkage and try to identify for those who were anti-HCV positive, who did not come out for HCV testing, and even for HCV positive people who did not come out for DAA treatment. We all have the data, and we can do a very good follow-up. And I think this is a so-called, we use this big health data, and with this help of the artificial intelligence, and we can try to have a more precise focus of this what effort we have to emphasize. And this kind of data linkage is definitely very important, and it's a time for us to use digital and smarter technology to help us to do HCV elimination program. Yeah.
Thank you very much, Prof Chen. I'm going to turn to Dr. Clapham to my left here on the panel. Now, if I understand correctly, your expertise is in modeling. Is that correct? Okay. Tell us what kind of models have been created with HCV. Dr. Ward mentioned there's some kind of tool that you can use to kind of plug in the different numbers and calculate disease burden, and it has all of that. Have you had a chance to look at that? Are there other examples? What do you think about that? And I don't know actually if Singapore's plugged their numbers in yet.
Yeah, I also don't know, but would like to know if anyone in the audience knows. Modeling can be really useful in this arena, and there's two reasons why it can be useful. The first that we've touched on but haven't really got into the weeds of is the fact that the reason, we're treating people because we want to stop them going on to having severe disease, to stop their individual symptoms or death that could happen. But we're also treating people to stop transmission. So hepatitis C doesn't have a vaccine. It doesn't have anything like that can be used for prevention. And so that secondary effect is going to be a really important part of the process and the reason for treating, which will lead me on to my second point, which is thinking about the cost effectiveness of these things. So, we can put them into our transmission models where we're able to get those second order effects of the fact that not only do you treat this person in front of you and you help them, you help the people that they could have then infected further down the line. And putting that into the models and into the tools is going to be a really important part of thinking about how we do that. Of course, those models will have to be adjusted to each setting. We've heard that the transmission setting in different countries is very different. And that these kind of tools that can be used in different places can be useful, but it is worth also thinking, within a country, what specific models and tools are needed for that setting.
Well, one of the questions has to do with the situation across ASEAN countries. So it's not just limited to Singapore. And the question is actually about requiring good estimations and uncertainty of infection and disease burden. And that is really important for you in your modeling, to have accurate data to work with so you can make the right assumptions. In your experience across ASEAN countries, this is our backyard, right? From an HCV perspective, is there any watch outs? And also from a policy perspective, because it costs money to start doing screening for possibly a low burden of disease to these countries, what are your thoughts on this as it pertains to what you do?
Yeah, so, I think generally we would, we think, the more data the better, but of course you're right that of course it costs money to get the data that you want to look at. And so the one reason for getting the data is to put in the models so that we're able to really understand the situation and we're able to understand the impact of what's put in. But the second is also this monitoring piece, and I think that's another really important one, that if we don't know where we start and we don't track what's happening along the way, then we are not able to say whether it's been effective, we're not able to say whether it's been a good use of money. And so I think that's a really important rationale for collecting those data. But not in every setting do we need to go out and do another survey in the general population. Maybe it's there. Maybe we know the prevalence in the risk populations also. Maybe all of those bits are there. But if they're not, then sort of also being targeted in the information that's being collected and how long it will be collected for is an important part of the strategy.
Thank you very much. Based on the conversation so far, I wonder if there's anyone in the room who wanted to make a comment, or any of the panelists, if something's occurred. Yes, please go ahead. There's actually microphones there if you want to run up. Sorry.
Hello. Okay, got it.
Yeah.
Yeah, so thanks very much for the presentation and the robust discussion in the panel so far. It's all been very enlightening, and it's very encouraging because I'm Gerard. I'm from HCSA Community Services. We actually have, as of this year, started running a HCV testing program, and because our charity, our social service agency, works with ex-offenders as one of our main beneficiaries, so it's been a known issue for us for a long time. That, of course, as the discussion has shown, that HCV is very prevalent and a high-risk population for the ex-offenders that we serve. So as of this year, we started a testing program that highly encouraged and even did a lot of the legwork and a lot of create basically a pathway for a lot of our beneficiaries, ex-offender beneficiaries, to come forward to get tested for HCV. And if they tested positive, they're of course given the directions and the linkages towards seeking proper treatment. And right now we're working with one of our partners in Tan Tock Seng Hospital, but of course also looking to work on a national basis as well. So at this point, we're sort of like near the halfway mark in our program, and we were very encouraged first and foremost by the participation rate. Pretty much almost every participant, every ex-offender at least in our residence, and also having worked with residences from other halfway houses in Singapore, it's been a tremendous tremendous eagerness to take up testing with our program. And so we found about 30 to 40% of them test positive as expected. And we're now at a stage where we're trying to link them to care with the hospitals. However, one of the challenges we find now is that because of their background, of their socio-economic status, that they are ex-offenders, they've just come out from incarceration, finding employment, sustainable employment, is actually a challenge for them. So getting income that would help support the family, not just themselves, even if they have children or grandchildren, and trying to make it sustainable is quite a challenge for them. And so comes along the point where they get tested positive for HCV, and then they realize the cost that it involves for testing, for confirmation testing, and then for treatment. Is actually quite astronomical for them. It might not seem too much for an average person, earning a decent income. For them, it's a choice between getting cured or trying to live with something which they feel doesn't impact their life immediately, but of course we all know it has severe consequences down the road. So the challenge for us right now is trying to see how we can get them to commit to the treatment, as we've seen in the case study with Taiwan. With when all the points are connected from end to end, the participants will go through and the treatment, and they will be successfully recovered from that. But the challenge here is now, how do we link? All of them have come forward to do testing. They know, those who are positive know they are positive, but how do we get them to follow through treatment when they can't really afford treatment on its own? There's subsidies provided to them, but even if the current subsidies provided to them, it's still not within their reach. So my question on this is, for the case study of Singapore, as you've talked about, we're very possible for us to close this gap. Very possible for us to eliminate it. And all it takes is just for this. Now we've gotten a high-risk group come forward, test positive, and are eager to seek treatment. How do we ensure that they can get treatment regardless of their socio-economic status, their ability to pay for it? Is there a possible way and a conversation that we should be having with perhaps the government or with the healthcare sector to see how we can close this loop? Because I think we can definitely do that. Yeah, thank you very much.
Thank you so much for the great example. It's very heartening to hear about this grounds-up approach, right, to a clear public health situation. It doesn't always have to go top-down. This grounds-up approach is really important. One suggestion, if I may, just from my own personal experience, and you may have already started doing this and we need to learn more about how to support you, is through the idea of foundations or charities that can do that for you. But clearly that's closing a gap that might be, trying to close a gap that might require a lot more assistance than just straight up subsidies. I wonder what we can learn about Taiwan, because Dr. Pu, you talked about going into the prison population. Now we're talking about a population that was in prison but is no longer there, and they do face different challenges. And I think that something else that you raised, what was your name again? Gerard. Something else that Gerard raised is important too, that we haven't talked about here so much, is that mental health aspect of knowing that you're living with this chronic disease that could potentially progress into something that's going to kill you. That's pretty intense. And how do you live with that, knowing that there is a treatment that you can't access? How do you approach this population in Taiwan?
That's it's the one issue that we just discussed recently, because we have expanded our, we reach out just not hepatologists. We try to empower the GP from general clinics and also other disciplines like ID, infectious disease. Doctors already know this for long, and then in this year, the workshops, the educational workshop, reach out to psychologists, not psychologists, how do we say that? 精神科
psychiatrists,
yes, psychiatrists, yeah, but they have their own problem. That just mentioned that patients are in the institution. So there's one model that the hepatologists go to the mental in institutions. They work with a psychologist. They screen first within their institution, and then collect the positive patients, and the hepatologists come in one day and routinely finish their treatments. So in Taiwan, there's really the collaboration model applies to many medical society areas. And we are lucky that our co-payment for this drug is pretty to nothing. Yeah.
That's right.
So screening is free, the treatment is free, but the registration fee for the hospital, because they are have this service that maybe $200 to $450, which could be minimum to people in this room, but quite a number for HIV patients, mental illness patients as such. So that could be our limit also. So again, the charity NGOs are happy to assist us. So, but it's our responsibility to highlight that issue. So the people with they came for help. So that's what our office is doing.
Was that a good response for you? Did you have any other questions you wanted to ask?
Yeah, from Dr. Lee, that there is no national plan right now. So I'm wondering whether this would be an opportune point for us actually when we are formulating this national plan, if we get there, whether government assistance and the health sector could come in to kind of close this gap, because I think from what we're observing on the ground here with our beneficiaries is that they are eager to get treated, and they would just go through with it if they can just afford it. But I think right now the dilemma for them is, of course, whether do I put a good chunk of money that I may not even have on a treatment for myself, or choose to just wait it out, because the effects of the HCV is not so bad right now. So where do we go from here? Now this is that gap that we need to close. Yeah.
Well, maybe Dr. Lee, you could take Gerard's comments and take that forward.
Right. Listening to Gerard's experiences, it is, well, I can feel his passion, and as a HIV physician, we have experienced this for many years in terms of getting patients who may not be able to afford the medications and making sure that they are then started on medications. There are various subsidies. As you know, these subsidies are means tested. So there are patients who are either HIV or HCV. If they really can't afford the medications, then the Medifund will take care of all the costs of the HIV drugs or the DAAs for hepatitis C. So I think for us, it is important to let them know that as long as you make it to the clinic, there is already a step in the right direction. And then from there, it will take a bit of time and patience and effort on their part to submit documents to make sure that they are really to go through the means testing process to get a subsidy. So in some of our patients, they actually receive the treatment without having to pay out of their pocket. So that's that. I think also coming from the experience of caring for patients with HIV is that I think for HIV there's a lot more years of experience and there's much stronger advocacy, but not much for hepatitis C. I think in that space for advocacy, I think more needs to be done. And then I think that will segue into what I think what we can do forward. So number one would be a elimination program, step by step, a strategy on how we can go about doing it for Singapore. And from there, then we could possibly apportion what are the resources needed in each of these at-risk groups, and in terms of testing, in terms of linkage to care, and in terms of the medications. And then not only that, subsequently patients who are cured and who are still at risk still have to undergo that screening again. So I think once we have a coherent program, then I think things will start to sort itself out in that way. And I think for the frontliners who are seeing patients or dealing with the clients, I think we're always ready to help them along the way. Thanks.
Got an advocate there. Yes, please, go ahead.
I'm a Taiwanese as well.
There we go.
So I'm really passionate about Hep C. I like to applaud Taiwan, which is a non-member for WHO, yet you can still achieve the WHO goal. And being a Taiwanese, I think you did very well. So the second comment is regarding the cascade for the Hep C patients. Now we know that Hep C patients, their cascade, so previous study in Singapore has shown that if 100% of people has been diagnosed, only about 20-25% of people complete or receive treatment.
That's right.
Part of it is also, related to the HIV population. These people, you really need to knock on their head and tell them, hey, you need to come for treatment, come for follow-up. It is difficult because ex-offenders need to find a job. And I agree, sometimes the subsidies are not enough for them to to come and entice to get treatment. Regarding the national goal, so there has been a Hep C modeling done for Singapore, published in 2021. According to ACE, in the last 2 years, since 2019, since the subsidized DAA treatment, we are actually on target. Now, that has been dropped because we clear out most of the warehouse patients in restructured hospitals. We don't have a structured program in prison to treat. Okay, so only until recently did they do an opt-out screening program, where they should have done a universal screening program. There's a lot of difficulties there. 2 years ago, 2019, myself and my colleague actually presented a national plan or ideas on how to do it and how much it cost to someone very high up in Ministry of Home Affairs. We were being told this is too expensive. Now, if you ask me, war on diabetes is much a bigger fish to fry. Hep C, the 0.6% national prevalence, is actually an ikan bilis, if you know what I mean. So if you cannot get rid of a simple, infrequent diseases, although it's highly stigmatized, how would you be able to fight a war against diabetes? So I think if there's governmental agencies here, it is not expensive to treat, to cure, eradicate. We can do it, but we really need a national plan. Thank you.
No, thank you for that perspective. I think the concept of expensive is something that we need to think differently about. So I've been spending years talking about value-based healthcare, but we'll do that at another symposium that I moderate. But for now, we only have a few minutes left, and I want to make sure, Dr. Padrana, you get a chance to issue a call to action or some advice to those of us sitting in Singapore who wish to also develop this HCV elimination plan. And then I would like to turn it over to Prof Chen for his closing remarks. So Dr. Padrana, are you there?
Yes, I'm here.
Great.
And eagerly listening. I think so many of our countries share very similar experiences, so thanks for sharing that anecdote from the prison system. In Australia, I think having a national strategy has provided the framework for continued investment from the government, and that is what I'm hearing is really critical and perhaps what's missing in Singapore. The strategy helps lay out the foundation. It also provides really clear guidance to the sector as well as to investors. So it might be mostly the government, but also there are other investors. So that's one thing to consider, is having a clear strategy allows the sector to come together to advocate and then to address the sort of funding gap. In Australia, we've had a very clear return on investment. We've got a lot of data to say this is what the investment cost us, and this is the return that we will receive. And I'm very glad to announce that as of 2022, we will start to see cost savings from the hepatitis C elimination investment. That is fantastic news. And that is really because we're shifting costs from disease management to costs of prevention. And now we are reaping the benefits of having people cured. So we are reducing the costs, the healthcare costs. So these are real, tangible things that policymakers understand and like to hear. Hep C is a positive story. And when you look at the countries around Australia, Taiwan, there is, resounding evidence that it works, and it can be cost effective, it can be cost saving, and it can be hugely beneficial to populations that are experiencing severe comorbidities, that also experience disadvantage and poverty. And so you really are helping a group of people who don't necessarily benefit from other healthcare services. I think this is very, very important. And it's an equity issue as much as it is a healthcare issue.
Thank you so much, Dr. Padrana. Congratulations. I think we should all give Australia a round of applause for recognizing cost savings so early on. Wow, incredible. Prof Chen, may I ask for you to give the closing remarks since you are the chair of this session? Thank you so much.
Okay. I would like to thank all the panelists. You have shared your successful story, also your challenges and you faced. And I think this elimination of hepatitis C is definitely very important for all the countries, even the countries with low prevalence. But I would like to emphasize that for the low prevalence country, we have to adopt it more precise screening program and try to identify this high-risk group, and then you can have a more cost-effective way to solve the problems. And with regard to this health inequality, I consider that for the remote area, and we can arrange certain kind of so-called outreach program. We have a mobile system, mobile team to serve the people in this remote area. For example, in Aboriginal area in Taiwan, and also for this special high-risk group. This kind of outreach program are also very important. And in Taiwan, we already loosened this the restriction and for the prescription of the DAA is not only by hepatology. We're all the GPs and diabetologists or kidney physicians can also prescribe this the DAA to the patient. If they have some difficult cases, then they can refer for the hepatologist. And finally, I would like to emphasize the importance of public-private partnership. And I'm glad to hear that there's a lot of charity groups engaged in this screening program. I think it's very essential for to have implement a very good national program. And through this kind of public-private partnership, we can provide this benefit to more infected people. And trust me that as long as we try our best to have a good national program and through a good design of some kind of modeling methods and try to identify that a good targeting population, then it can even be achieved much earlier than 2030. With that, I would like to thank all the panelists and also all this audience for your participation. Thank you very much.
Thank you very much.
Thank you for the insightful discussion. Before we wrap up the session, I'd like to invite all the speakers to take up a group photo. Thank you, Dr. Lei, Dr. Pu, Dr. Lee, Dr. Clapham, Prof Chen, and Dr. Pedrana. We have come to the end of today's event. Thank you very much once again for joining us. Refreshments will be served at the foyer. We wish you all a good health and a good evening ahead. Thank you.